Thank you very much, Katrin, for this introduction and my talk here, peripartum cardiomyopathy. Here are my disclosures. And my talk is based on several review articles and also the guidelines of the European Society of Cardiology of 2018 for the management of cardiovascular disease during pregnancy, and clearly also on the recent position paper of the Heart Failure Association of the ESC, which I chaired. So the diagnostic criteria of PPCM are shown here. PPCM is defined as a cardiomyopathy that develops to the end of the pregnancy, usually in the last month of pregnancy or in the month following delivery, where no other cause of heart failure is found. And in fact, it's a diagnosis of exclusion. And the left ventricle of the heart may not be dilated, but the ejection fraction is nearly always reduced to below 45%. Normal ejection fraction is 60 to 70%. 2/3 of the PPCM patients are diagnosed at the time of delivery or within the first month after delivery. And the prevalence is highly divergent worldwide. For example, in Western Europe, we have a prevalence, an incidence of about 1 to 1,000 to 1 to 3,000, but in Africa it's much higher, and also in, for example, Haiti. And the mortality is pretty high, between 2 and 30%, which is very high in my view for previously healthy young women. The pathobiology of peripartum cardiomyopathy is not completely understood, but it's clear that a toxic cleavage product of prolactin, which is shown here on the left, is involved, and this is made from prolactin by cathepsin D in the presence of oxidative stress, leading then to endothelial dysfunction. Also, the soluble fluid is involved here, coming from the placenta and also leading to endothelial dysfunction. Ultimately, this leads to cardiomyocyte apoptosis and damage. The most important question for us as clinicians is it PPCM or not? And the diagnostic pathway is shown here for patients with suspected PPCM. And in all patients, you should suspect PPCM when they show symptoms like dyspnea, peripheral edema, chest pain, palpitations, fatigue, cough. So this is a very broad arena of symptoms, but you can then narrow it quickly down with some crucial diagnostic tools. For example, the natriuretic peptides, the NT-proBNP or BNP, they are usually not elevated in patients with heart failure, and also echocardiography is very important. Also, the ECG is not specific for PPCM, but it's almost always abnormal. At least the patients have sinus tachycardia or T-wave changes. The PPCM diagnosis should be clearly suspected when the left ventricular ejection fraction is below 45% and when natriuretic peptides are elevated, and then PPCM is likely. However, it's also necessary to exclude other heart diseases, for example, chemotherapy-induced cardiomyopathy or congenital or valvular heart disease. When not natriuretic peptides are elevated, but ejection fraction is higher than 45%, then it's usually extracardiac. And when natriuretic peptides are elevated and ejection fraction is above 45, then you also have to think about right ventricular failure, pulmonary embolism or so. The differential diagnosis is huge, and I do not go into the details, but you see here potential differential diagnosis, for example, Takotsubo syndrome, which is a specific cardiomyopathy, but in these patients you have more isolated or located cardiomyocyte damage and not a global damage. Or, very important, as mentioned, the pre-existing, previously unknown congenital heart disease. The picture, the clinical picture of PPCM can be extremely variable. You see this here, you can have patients with only mild PPCM that are stable and that do not go to an emergency room or so, but they only go to you, for example, and have these symptoms of heart failure. But it can also be an acute heart failure syndrome, even a cardiogenic shock, very severe acute heart failure. You see on the right here, hemodynamic instability, respiratory insufficiency, and these patients clearly have to be treated on intensive care unit. And as these patients usually not arrive in the hospitals from 8 to 5, but outside the working hours or during the weekend, every larger center should have established a task force for acute heart failure during pregnancy. This is not only important for PPCM, but also for other patients with acute heart failure in pregnancy. And usually there must be a very close collaboration between cardiology, obstetricians, neonatologists, anesthesiologists, and others to ensure that there's an appropriate diagnosis and treatment for these patients. And clearly, you have to keep in mind the status and prognosis of the fetus, but also of the mother. And these are very hard decisions, and such a task force is very helpful. One patient we cared for some years ago is depicted here. It was a typical case of a young mother 2 months after delivery, and already several times before she had approached her general physician because she was tired and suffered from dyspnea, but the physician did not realize that she had heart failure, and at the end she went to a hospital nearby and was in cardiogenic shock, and then she was transferred to my center, and with a blood pressure of 55/20 at arrival, despite 3 catecholamines on board. And in this patient, we immediately installed intensive care treatment. We did not only introduce central venous catheters, one Ganz catheter, but also an impeller pump, which is a pump which unloads the left ventricle. And the ejection fraction in this patient was below 10%. And with this pump, which we insert from the femoral artery, we can unload the ventricle and improve the blood pressure. And you see here on the right side, she had a 3-week course of intensive care treatment. And at the end, we managed her without urgent heart transplantation or implantation of a operatively implanted ventricular assist device. And she recovered almost completely. And 4 years later, now she's a normal young woman who is working. What is the pathophysiology of the bromocriptine? I already mentioned the prolactin, and this is also the basis for a therapy with bromocriptine in patients with PPCM, because bromocriptine, as you know, reduces prolactin and then also reduces this stimulus of these 16 kilodalton toxic prolactin. And this was shown in a seminal paper almost 15 years ago. And then 10 years ago, in a pilot study in South Africa, it was shown that patients treated with bromocriptine had a much better outcome as compared to patients not treated, regarding death or regarding also improvement of left ventricular function. And also in Germany, in our registry on PPCM, we could show that patients that improved after PPCM usually had been given bromocriptine, whereas non-improvers did not. So we started to do a study on bromocriptine in PPCM patients, and after these pilot studies showing so beneficial effects of bromocriptine, we were not allowed by the ethics committee to do a randomized study against placebo, and therefore we did a study of 1 week bromocriptine versus 8-week bromocriptine, and the dose was 2.5 milligram 2 times daily in the beginning in these 8 weeks, and then lower to 1 times 2.5 milligrams, so much lower than you as obstetrician usually use it. And in the patients here, in both groups, there was an improvement of left ventricular ejection fraction after 6 months. This was not clearly different. When you go to the most sick patients with an ejection fraction below 30%, you see here on the lower panel that then the improvement in left ventricular ejection fraction was tended to be more than in the 1 week treatment. And then we also compared this in a non-randomized manner, I have to admit, with the patients treated in the United States without bromocriptine in the IPEC registry. And you see here that in the patients with an ejection fraction below 30% in the beginning, in our study with bromocriptine, there was no mortality and no heart transplantation or ventricular assist device implantation, whereas mortality was 15%, and in addition, heart transplantation and VET implantation was 90% in these American studies. So we are convinced that bromocriptine is an efficient therapy in these patients. There was also another non-randomized cohort study showing that bromocriptine appears to be associated with a more improvement of left ventricular ejection fraction, as you can see on the left side, as compared to the standard medical heart failure treatment on the right side. Based on these studies, the European Society of Cardiology in 2018 here put a class 2B indication for bromocriptine treatment in patients with PPCM to stop lactation and enhance recovery of left ventricular function. And as there had been reports that during bromocriptine there may be thromboembolic complications, it should also be accompanied by prophylactic anticoagulation if there is not another indication for therapeutic anticoagulation. Clearly, it's very important to recognize that heart failure drug therapy is mostly contraindicated during pregnancy and only to be used with high caution during lactation. Here's a nice table depicting all these drugs. I do not go into the details, but this is in the position paper of the Heart Failure Association of the ESC. As you know, ACE inhibitors, angiotensin receptor blockers, mineralocorticoid receptors antagonists are, and also the ARNIs, the new heart failure drug called Entresto, they are all contraindicated during pregnancy. And partly they can be used during lactation, but in my view, patients with at least with severe heart failure should not lactate because this poses another threat to them. So what is then done with the patients afterwards? They usually have to be treated with these heart failure drugs until there is a recovery of left ventricular function. And as we have seen, many of them recover during the first 6 months, and many do recover during the additional 6 or 12 months. And then only when there is a complete and sustained recovery of left ventricular ejection fraction, then you can think about tapering these drugs, and usually should wait another 12 months at least before you think about tapering the dosages of these medications or completely skip them because there have been relapses observed in these patients. Clearly, diuretics can be reduced when no longer necessary. It's also important to recognize that the cancer prevalence is increased in PPCM, and this is associated with less left ventricular recovery. Also, gene variants associated with DNA damage have been associated with PPCM, and these patients with a cancer history, they do not recover as well as the other ones. What about subsequent pregnancy in PPCM? Very important question for these patients. Clearly, as you see on the right side, if the left ventricular function does not recover to above 50%, you have to really advise against pregnancy. If the PPCM patients recover to an ejection fraction above 50%, here then you can perhaps undergo another pregnancy, but with a very, very narrow re-evaluation of the patients every 4 weeks after the 20th week and every 2 weeks after the 30th week. Here's our algorithm, and then the delivery is usually planned after the 34th week. This is the second last slide. It's a summary of the largest registry ever published on PPCM, 740 patients worldwide. And you see that you cannot rely on physical examination because 40% of them do not have peripheral edema, 40% do not have pulmonary rales, and you also have to keep in mind that the mortality rate is quite high. So this is my take-home message. And you see PPCM is a cardiomyopathy with an ejection fraction below 45% at the end of the pregnancy or the month thereafter. The clinical spectrum is broad. high degree of suspicion is crucial. ECG, echo, and natriuretic peptides are essential for the diagnosis. Standard heart failure drug treatment should be given respecting the contraindications during pregnancy and lactation. Consider prolactin blockade with bromocriptine, and after LV recovery only, very cautiously, the heart failure medications may be tapered, and cancer incidence is increased and associated with less recovery, and subsequent pregnancy may only be considered after complete LV recovery that is stable after tapering of drug treatment. Thank you very much.
Thank you for a fascinating and very, very important talk. The work you have done is so important and valuable. We have a number of questions. I'll start with questions about bromocriptine itself and other dopamine agonists. One question is from an anonymous attendee who says they do not have access to bromocriptine. Do you have any experience with cabergoline?
Very important question, because sometimes today, also in Germany, we do not have bromocriptine available. In fact, there is no data on PPCM regarding cabergoline, but we think it's a useful alternative, and we also use it in patients when we do not have bromocriptine. But when you have bromocriptine available, you should use it, as there is more evidence for this.
Do you think there is a good argument to consider doing another trial now? As an endocrinologist, I'm aware that cabergoline has a much better side effect profile and is easier for women to take. Would you consider doing this?
Yes, it's an important question, and we are also thinking about other prolactin antagonists, but it's very hard, as you recognize, to do a randomized trial, but perhaps it would be useful to compare bromocriptine against cabergoline.
Absolutely. I have a question from someone about dosing and duration. Could you expand on this a little further, please?
Yes, so in patients that do not have cardiogenic shock or acute severe heart failure, we only use the 1 week regimen, for example, on outpatient basis, which is only 2.5 milligrams bromocriptine for 1 week. And in addition, we use low dose heparin in a prophylactic dosage. In the patients that are more sick and that have more severe, moderate to severe heart failure, we use the 8 week scheme. That means 2 times 2.5 milligrams prolactin blockade with bromocriptine for 2 weeks, and then for another 6 weeks, 2.5 milligrams once daily.
Thank you very much. A question from Stephen Burrell. If peripartum cardiomyopathy is related to a toxic product of prolactin, is it more common in breastfeeding women postpartum? And it would be interesting to know your thoughts about this generally.
There is no 100% clear data on that, because there is no study on the prevalence of prolactin on a population basis. So therefore, we don't know. We can only go retrospectively when patients have been diagnosed with PPCM, and then the picture is not completely clear. I have the impression that perhaps more patients are breastfeeding, but this may also be because more patients, more women breastfeed because always it's told them that it's good to breastfeed.
And a question about preeclampsia. If a woman has severe preeclampsia and all other criteria for peripartum cardiomyopathy, which should they be classified as PPCM or hypertensive heart failure?
It's very important to recognize that preeclampsia is usually much more prevalent than PPCM, and the most patients that have heart failure in the context of preeclampsia have a hypertensive heart failure, and they do not have a reduction of left ventricular ejection fraction. And only a very small part of the patients with preeclampsia develop later on PPCM with a markedly reduced ejection fraction. So despite the fact that preeclampsia is a risk factor for PPCM, the majority of preeclampsia patients do not develop PPCM.
Yeah. There's also a question about the mechanism by which bromocriptine can enhance left ventricular contractility. You mentioned through regulation of cathepsin, but asking about more detail about, they say, the story of cathepsin and the interaction with cardiomyocytes. And is there a relationship of bromocriptine to troponin?
this is very hard and even not to answer, because there are, for example, also some Americans are highly critical against bromocriptine because almost 40 years ago, some people had made the experience that when you give bromocriptine to heart failure patients, that they may even deteriorate, but this had also been higher dosages of bromocriptine. And so there is a complex interrelationship, and clearly there is no direct effect of bromocriptine on cardiomyocytes. So it interferes with the complex pathophysiology, and you reduce the prolactin, you reduce this toxic product of which is cleaved from prolactin, but it's not so simple, and there's also no direct relationship to troponin.
There are a couple of questions relating to maternal ECG changes. One question is, how often is isolated asymptomatic sinus tachycardia associated with PPCM? And the second is, can it present with bradycardia?
So usually the patients with acute heart failure are tachycardic, and tachycardia is one important signal on the ECG for PPCM, but clearly is not specific to PPCM. And tachycardia is also associated with a worse outcome in PPCM patients. On the other hand, bradycardia is not quite often, and bradycardia, for example, is related to an AV block, and this is not a usual characteristic of PPCM. So bradycardia is absolutely not related to PPCM usually.
I'm afraid we have many more questions, but we will have to move on in a second. I will ask you one final question. You've been asked if you have a view on mode of delivery, whether it should be assisted cesarean section or not.
This depends on the clinical status of the patient. It has to be discussed in the task force. For example, when you have a patient in cardiogenic shock who needs a mechanical assist system, for example, then usually almost all of us would directly advocate cesarean section. But when you have a patient with only subtle signs of heart failure who is clinically rather stable, then I think, but you are the experts, the obstetricians, and they then go for a vaginal delivery.
Thank you very much, and once again for a wonderful talk. Thank you.
Thank you very much.
Our next speaker is Tim Kurabaz. Tim is an endocrinologist who did his PhD at Erasmus University in Rotterdam, where he did phenomenal work, many of you will know, that has addressed many of the difficult questions in thyroidology related to pregnancy. And he's going to speak to us today about clinical pearls for managing thyroid disease in pregnancy.
Thanks very much for the kind introduction, Catherine, and also thanks to the organizers for inviting me to speak on this excellent webinar series. So I'm going to talk about my favorite topic, which is managing thyroid disorders in pregnancy. Now, I have selected these topics for this talk mainly based on the timeliness of the current literature. So it's also going to be somewhat of an update perhaps for some of those who are listening. So to kick off with hypothyroidism, we've often been shown these types of studies that show that TSH decreases during pregnancy because of the stimulatory properties of HCG in pregnancy. And this has led to certain recommendations that the upper limit of TSH should be reduced for diagnosing hypothyroidism to about 2.5 or 3 milliunits per liter. Now, we have now much more data, and when you meta-analyze that type of data, it actually shows that reducing the upper limit of TSH for the diagnosis of hypothyroidism actually causes considerable overdiagnosis, not only of overt hypothyroidism, but also especially of subclinical hypothyroidism, which would be overdiagnosed in 1 in every 9 otherwise healthy pregnant women. So therefore, it is really advised to calculate hospital-specific reference ranges. But because this is often not possible in various centers, the 2017 American Thyroid Association guidelines have now put in a sort of second tier, which is the recommendation to use reference ranges that have been calculated in a hospital that is similar to your own hospital. Now, if this would also be unavailable, the upper limit of TSH can be set to 4 milliunits per liter rather than 2.5 or 3 milliunits per liter. Now, it's also important to realize that this should not be confused with the treatment target of TSH, which is actually less than 2.5 milliunits per liter for women who are treated with levothyroxine during pregnancy. And this 2.5 milliunit per liter treatment target is based, of course, on healthy pregnant women who are very unlikely to have a TSH above 2.5. And also this is set to make sure that we do not undertreat women as pregnancy progresses and the need for an increase in thyroxine is typically there. A question that I also often get is whether or not we should be treating subclinical hypothyroidism. Hopefully, of course, after having diagnosed it in the correct way, like I just mentioned. Now, the short answer to this is that we actually don't know, but there is a side note to that, which is that we should be aware of a potential risk of overtreatment based on some recent data from our group and that of others. As for subclinical hypothyroidism, there's a small randomized controlled trial in which they were able to treat women from about 13 weeks pregnancy, showing that there's a considerable reduction in preterm birth, and that this was especially the case for subclinically hypothyroid women who were also found to be TPO antibody positive. There have been 2 larger randomized controlled trials in which treatment was started at a later gestational age that actually didn't find any reductions in the risk of adverse pregnancy outcomes. Now, the main outcome in those trials has been child IQ, which was also actually a negative result, even though there wasn't any statistical power for those outcomes. And in those trials, they also didn't stratify for TPO antibody status. That is something that hopefully we can do in the consortium on thyroid pregnancy, which I will show you a slide on later. So the general idea currently about the treatment of subclinical hypothyroidism is to first check TPO antibodies, and if these are positive, to start treatment with levothyroxine in a low dosage and then titrate this up as pregnancy progresses based on TSH of 3 to 4 measurements. If TPO antibodies are negative, this is really a gray area, and we don't know whether we should advise people to treat or not, so this is really up to the treating physician. But the side note I would like to make here again is to start with a low dosage of levothyroxine to ensure that you do not overtreat the patient. On to Graves' hypothyroidism, also something in which the recommendations have considerably changed over the last couple of years. A question that's often asked is whether we should prefer PTU or methimazole or its prodrug carbimazole for the treatment of Graves' hyperthyroidism in pregnancy. And the short answer to that would be to prefer PTU. And the reason for this is that, first of all, the absolute risk increase for fetal birth defects, which is of course a main side effect of these drugs, is slightly lower for PTU than it is for methimazole. But also, when you look at the studies, the specific birth defects to which PTU exposure in pregnancy is associated with typically are much less severe than those fetal birth defects that we see for methimazole exposure. And I've put some examples on my slide here. Another argument to favor PTU comes from this very good Korean study in which they actually showed that there is a dose-dependent association for methimazole with the risk of fetal birth defects, but again, not for PTU, favoring, again, the choice for PTU. The follow-up question is then, of course, should we be switching women who became pregnant while taking methimazole or carbimazole to PTU as soon as we find out that they are pregnant? And this study was the only study to investigate this question. And what they found was that women who continued methimazole during the first trimester and pregnancy onwards actually had a similar risk of fetal birth defects as women who were switched from methimazole to PTU in the first trimester. So really there isn't any evidence for a benefit of switching, but of course there is a risk of biochemical deterioration and an increase in hypothyroidism once we change the way that we treat this thyroid condition. One strategy that we can actually use to limit the exposure to antithyroid drugs is to try and stop them early in pregnancy. So most of you will know the teratogenic period is approximately between 5 or 16 weeks. And if I now project the risk of the relapse of Graves' hypothyroidism after we stop antithyroid drugs, you can see that there's actually a time lag here that we can use to our advantage, because Graves' disease typically does not immediately relapse after we stop antithyroid drug treatment. The median time to relapse of Graves' disease is about 3 months. So what we hope to do with this strategy is stop antithyroid drugs as soon as the pregnancy test is positive. And then even if Graves' disease does relapse, hopefully we have already bypassed the teratogenic period and can restart methimazole or PTU after the 16th week of pregnancy. Now, the risk of relapse of Graves' disease is about 30 to 70%, and it depends on various clinical characteristics. Here you can see an overview of those clinical characteristics. In general, you can consider to use this strategy if a woman has been treated for at least 6 months prior to pregnancy and has had a normal TSH during treatment, and also if they were treated with a relatively low dose of antithyroid drugs. And a low dose of antithyroid drugs is considered to be about 10 milligrams or less of methimazole, or the equivalent dose of carbimazole, or the equivalent dose of PTU, which is about 1 in 20. So that will be 200 milligrams of PTU as a total daily dosage. Of course, it's important to keep on monitoring these women throughout early pregnancy every 2 weeks to see if hypothyroidism would relapse. We're of course always worried if a woman has Graves' disease about fetal or neonatal Graves' hypothyroidism. And that is of course because this form of hypothyroidism in the neonate is a major risk factor for adverse pregnancy and adverse child developmental outcomes. And we all know that TSH receptor antibodies and also free T4 passes the placenta onto the child and actually cause the same distinct features that we see in the mother. And this picture here on the right is, I think, is very typical, actually showing neonatal Graves' disease with neonatal Graves' ophthalmology. Now, another thing that's also important to realize, but that is often forgotten, is that poorly controlled Graves' disease in the mother actually suppresses the hypothalamic pituitary thyroid axis in the child, and this can lead to poor development of the cells that actually produce TSH in the pituitary. Therefore, children of mothers with poorly controlled Graves' disease in pregnancy have a much higher risk to develop central hypothyroidism later in life. And therefore, our pediatric colleagues should be asked to follow up these children, for example, on a yearly basis. We, of course, monitor the child by checking the heart rate, fetal growth, size of the thyroid, and in some cases, even cord or amniocentesis is necessary. But I would also like to stress the importance of maternal monitoring in monitoring the child. And we can do this by measuring the thyroid function in the mother and also measuring TSH receptor antibody concentrations. As you can see here on the left, maternal thyroid function measurements very well correlated with child and fetal thyroid hormone concentrations, implicating that what we measure in the mother is a very good insight into what's actually going on in the fetus or in the newborn. What you can see in this slide on the right is now a more than 30-year-old study, which is still very important, showing the risk of newborn hypothyroidism in women treated with antithyroid drugs for Graves' disease in pregnancy. And what you can extract from this graph is that this risk of fetal hypothyroidism is much lower in women who had a relatively high free T4, so at least in the upper third of the normal range. But this risk starts to considerably increase if the free T4 was slightly lower than that. And that is probably because the fetal thyroid gland is more sensitive to antithyroid drugs than the maternal thyroid gland. So there really is a risk of fetal overtreatment, because also these drugs, of course, pass the placental barrier. And based on this data and also mainly animal studies, it is therefore advised that the treatment target for antithyroid drug treatment in women with Graves' disease is a free T4 in the upper third of the normal range. We also, of course, measure the TSH receptor antibody concentrations in the mother. And a very good recent meta-analysis has actually shown that there is not a single case of fetal or neonatal hyperthyroidism in the literature in which the maternal TSH receptor antibody concentration was above 3.7 times the upper limit of normal. So therefore, it is a very reasonable recommendation from the American Thyroid Association guidelines that if the TSH receptor antibodies are less than 3 times the upper limit of normal in early pregnancy, it's actually unnecessary to continue monitoring of the TSH receptor antibodies, especially because the typical trajectory is downwards because of the changes in the immune system of the mother. And even perhaps it's not necessary to, as intensely as normally, fetal monitoring the fetus in pregnancy. But this is, of course, as long as the mother is still biochemically well controlled, so has a normal TSH and free T4 concentration. So thank you very much for your attention. I would like to shamelessly plug some of my research efforts, which are ongoing in the Consortium on Thyroid and Pregnancy. This is a worldwide collaboration in which we have been combining individual participant data to perform large meta-analyses. And we're also now setting up prospective studies. So I would be more than happy for you to visit our website or to seek contact with me if you're interested in participating in any of our studies. So again, thank you for your attention.
Tim, thank you for summarising such a broad subject in such a short space of time with a lot of new, interesting, exciting data. And do remember at this consortium, Tim is doing fantastic work and collecting data, individual patient data for meta-analyses through this. So very worth collaborating. We have a lot of questions, so I'll give you as many as I can in the time we have. Starting with a question, how do you manage women with an undetectable TSH but normal free T4 and free T3 during the pregnancy?
That's a very good question. There's a few things that are important to know as well, because typically subclinical hyperthyroidism is something that we don't treat because the risks of antithyroid drug treatment do not outweigh the potential benefits. So what we typically see is that subclinical hyperthyroidism occurs in early pregnancy because of the effects of HCG on the thyroid. So if a woman presents with subclinical hyperthyroidism in the first 18 to 20 weeks of pregnancy, it's absolutely sensible to do nothing and to recheck thyroid function in 6 weeks. As soon as you see a decline in the free T4, you're probably safe and there's no need to check for thyroid function anymore in pregnancy. Now, if you see subclinical hyperthyroidism outside of this window, so very early onwards in pregnancy, for example, in the first 8 weeks, or after 18 to 20 weeks of pregnancy, it would actually be sensible to start checking thyroid function every 4 to 6 weeks to see if there's not an underlying cause, and also to check the TSH receptor antibodies. I am quite conservative with checking TSH receptor antibodies in subclinical hyperthyroidism, and that is because Graves' disease typically doesn't present with subclinical hyperthyroidism, but with overt hyperthyroidism with very high free T4 and T3 concentrations.
Thank you, Tim. And a question, at what TSH concentration would you consider restarting PTU after pausing in early pregnancy?
That is a very good question. I think we should definitely take into account the changes that we see in TSH over time. So, if the TSH has been 0.5 all throughout treatment, then and it remains stable at 0.5 during pregnancy, there's absolutely no reason to start. But when it has been 3 or 3.5, and then all of a sudden you see a decline to less than 0.5 in pregnancy, then I would be more worried. But I would also definitely take into account the free T4 and the T3 concentrations. If those stay normal, you see a slight decrease in the TSH, I wouldn't be too worried. But if you also see that those are increasing, it will really make sense to start. So it's difficult to give you a single number to consider restarting it. Although I think that less than about 0.4 is something that most people would start to worry.
And there's a question about what monitoring should be used for a mother with previous Graves' disease and with persistent TSH receptor antibody in high concentration.
So in those women, it would be very sensible to check if the TSH receptor antibodies are stimulating or are blocking. In some cases, they can actually be mixed. And this can be very difficult because in that case, there can actually be fetal hyperthyroidism or fetal hypothyroidism, depending on how much of these IgG antibodies are actually crossing the placenta. So that's the first thing that I would want to check in these women. Of course, you have a sort of in vivo model in these women, which is their own thyroid. So that can definitely help you to say something about the activity of these TSH receptor antibodies. Because if thyroid function is high, they're probably stimulating and vice versa. But if they remain euthyroid, the fetus is probably also still euthyroid. So I think that will be my first step to check in these women. Now, the real problem arises if you have a woman who still has high TSH receptor antibodies, but who has had a thyroidectomy before. In that case, you don't have this sort of functional readout that you can use the maternal thyroid function as. And in that case, there should be strict fetal monitoring. And again, it would also make sense to do a functional assay for the TSH receptor antibodies to see if they're stimulating or blocking.
Thank you. Now moving on from more hyperthyroidism related questions, there's an interesting question. What about TSH in the context of IVF? Would you consider a threshold of 2.5 or change it to 4?
So again, I would like to stress the threshold of 2.5 that we've been using for the diagnosis of thyroid dysfunction is very much outdated and not based on evidence at all. This has been introduced for pregnancy measurements and have then been sort of adopted by IVF doctors to be used during IVF trajectories or as a screening method prior to IVF. There's even less evidence for this cutoff in those women. So diagnosis of any thyroid dysfunction in a woman who is about to undergo IVF should be based on the normal reference ranges that you are using outside of pregnancy. In women who are treated with levothyroxine and undergo IVF, we know there is an additional strain on the thyroid, and we typically need to increase the levothyroxine dosage during the IVF trajectory, especially around the time of the HCG trigger in general. So you should definitely follow up thyroid function in that trajectory. And in the women who are treated, similar to in pregnancy, it actually makes sense to have a treatment target that's a TSH less than 2.5 milliunits per liter.
Tim, we're going to have to move on in a minute, despite having many, many interesting questions coming through, and maybe we will invite you back to consider the implications for fetal cognitive development and health in a future webinar. But very quickly, just if you could give me a fast answer, what are the antibody tests we should ask for in autoimmune hypothyroidism? Is there any value in antithyroid receptors, and should they be asked for?
It is extremely rare to have hypothyroidism that is caused by TSH receptor antibodies. It is definitely somewhere down in the basement of your differential diagnosis, but typically TPO antibodies are the way to go. And of course, thyroglobulin antibodies can also help you to diagnose autoimmune hypothyroidism. Now, if those two are negative, then you can consider to do TSH receptor antibodies, but I typically would not check those. So TPO and TG antibodies.
Thank you very much for an excellent and comprehensive talk. Our next speaker is Professor Michael Hinahan, who is Professor of Hepatology at King's College London and King's College Hospital. He's a leading researcher in liver disease in pregnancy, is currently leading on a European registry, and today is going to speak to us about challenges managing cirrhosis in pregnancy.
So thank you so much for the invitation. I'm just trying to change my display settings, which seem to be failing. So while I'm waiting for my technical difficulties to resolve, hopefully, just to make a couple of comments. The first thing to say is that not all patients with cirrhosis are the same. Second is that we divide patients according to whether or not they have compensated or decompensated cirrhosis. And second and thirdly, to say that in these patients with cirrhosis, their outcomes are very much dependent on whether or not we have individual patient data or alternatively big data. What is critical, I apologize, I seem to have my computer seems to have hung. I'll do the best I can.
Michael, we can see your screen, so hopefully
you can see my screen.
Most people can see this, even if you're not able to project fully.
Yeah, so basically, in general, people thought that the rates of pregnancy in cirrhosis were actually very, very rare. And what we can see is that over the last several decades, even in our own institution, the rates of pregnancy in both non-cirrhotic patients and cirrhotic patients has actually increased dramatically. At a country level, and actually these data are hottest off the press, there has been an 8-fold increase in the rates of pregnancy.
Michael, we just interrupt you. Airo, can you direct him on how to project?
Yes.
Say
Professor, Professor, if you can go on full screen and click F5, you will be able to project.
My program seems to have hung. What I will do is I will try and reload it.
Sorry about that.
I apologize.
It's okay. It's perfectly fine. But if you go on full screen, in that screen that you are now with F5.
F5, it is not changing. My computer seems to have hung.
We have 12,000 registrations from 171 countries. So maybe your computer is nervous.
I don't, perhaps it is. Perhaps it is.
Would it be worth us moving to the fourth speaker and coming back to Michael's talk afterwards?
Let me reboot. Perhaps I think that's the best thing to do, and I will reboot and re-log in.
Yeah. Okay.
I apologize for that.
That's fine. That's fine. We have lots of time. TP, are you there? Professor Mackenzie from
Hello.
University of California in San Francisco. She had a fantastic talk a couple of months ago on intrauterine transplantation for alpha thalassemia, and she wants to follow that up with what is it? In utero enzyme replacement therapy. So, TP, we are all yours.
Thank you so much, Kypros, for the invitation. I'm so honored to be here. As you know, I'm trying to work with many of you around the world to expand the repertoire of fetal therapy, moving towards more medications and stem cell and gene therapies that we can deliver just using an umbilical vein injection. And the main reason that I think that it's important to do this in the fetus is that we can potentially avoid immune reactions to foreign proteins. We are finding that things that we give to the fetus in gestation can cross the blood-brain barrier. And most importantly, hopefully we can prevent the disease progression. So it's kind of an enormously important time for fetal therapy, because now we can combine the effects of rapid genetic diagnosis in fetuses along with advances in fetal surgery and advances in gene therapy and genome editing. So we have a number of these therapies in our armamentarium, such as stem cell transplantation, enzyme replacement, and gene therapy. And these are some of my favorite diseases that I like to think about. Today's talk is going to be on lysosomal storage disorders. And I think that we can really improve outcomes. So this is kind of the pipeline of molecular therapies that we're starting to offer at UCSF. We have an ongoing trial of stem cell transplantation for alpha thalassemia major, and we're hoping to expand that to other common diseases like beta thalassemia or sickle cell disease. And today's talk is going to be on our emerging clinical trial for in utero enzyme replacement therapy. And we are speaking to the FDA and ethical organizations regarding perhaps in utero gene therapy in the future. So lysosomal storage disorders, as you know, are a group of diseases that are inborn errors of metabolism resulting from mutations in specific enzymes. And you all know that some of these, like MPS 7, can cause hydrops before birth. In fact, some studies show that if you have a fetus with idiopathic hydrops, they don't have any other reason that you can see, about a third of them will have lysosomal storage diseases. These can be treated after birth, usually with enzyme replacement therapy, so the recombinant enzyme specific to the disease, and sometimes with stem cell transplantation. But there are shortcomings to these therapies. One is you can have an immune response to the enzyme, which the body sees as foreign, and the enzymes don't cross the blood-brain barrier, so you can't treat the neurologic disease after birth. So we think that fetal therapy can prevent both of these problems. So to try to test whether this will work in patients, we first did a study in mice where we took mice that had MPS 7 and we bred them together. You actually can only breed heterozygous mice, so carriers, and then about a quarter of the litter will have actually MPS 7. And we injected the recombinant human glucuronidase, which is the enzyme missing in MPS 7, into the fetuses. And then we looked at a number of different endpoints. And I won't belabor this, but I'll just say that it was very successful in this mouse model. So first of all, we saw that the mice also die before birth. So this is, if you don't treat them, they have about a 15% decreased rate of survival compared to what you would expect. But with fetal therapy, we can rescue that to the expected. And then I'll just show you guys a video. This is what the mice look like. They're very, very slow moving, and they sort of look autistic. They don't move around. They're not curious at all. And they have these short faces. They have a very interesting phenotype. But this is a cage of mice that we treated in utero And we had to look at the genes of these mice again to make sure that they were actually the sick mice, because they look just like regular mice. We have trouble catching them, and they're much more curious. And when we did neurologic testing, they were stronger than untreated mice. Oops. We looked at the liver disease, which is a common thing that patients also get. They have these lysosomal accumulations. And in the treated mice, we had rescued the lysosomal accumulations. They have short bones if you don't treat them, but with the treatment, we had improved the bone length of the mice, which is an important thing clinically. A lot of these patients have short stature. And finally, we did show that we induced tolerance to the enzyme, which is an important goal because a lot of these patients develop such bad immune reactions that they're on pretty strong immunosuppressants, steroids and methotrexate after birth. So here you can see untreated animals developed a lot of antibodies, but the in utero treated animals did not develop any antibodies. And finally, we showed that the drug crosses the blood-brain barrier and gets into this very important cell type called the microglia. This shows that the drug is in microglia, and this shows that the brain inflammation, which is a brown stain that you can see very dark here in the treated mice, has been attenuated. So obviously we're not mouse doctors, so we wanted to put together a multidisciplinary team to develop a safe and ethical protocol for in utero infusion of the enzyme. And so what we did was, this is our multidisciplinary team. Paul Harmatz is a medical genetics doctor who does a lot of the postnatal clinical trials here in San Francisco. So we put together a clinical protocol. We surveyed the patient groups, and I'll show you the data about what patients think about this potential therapy. And we recently got our FDA approval to do a phase 1 clinical trial of 10 patients. So this is the most important slide. So basically our clinical protocol is that we would confirm the diagnosis either using CVS or amniocentesis. And we think that the patients are going to be probably families who already have an affected child so that they know that they're carriers and would be diagnosed. And we did get permission, because these are all such rare diseases, we did get permission to treat a number of different MPS disorders, so MPS 1, 2, 4, 6, 7, infantile onset Pompe, neuronopathic Gaucher, and Wolman disease. So once the diagnosis is confirmed, we would be injecting the recombinant enzyme through the umbilical vein, the exact same protocol that you would do for PUBs or in utero transfusion. And we have to inject several times, so every 2 to 4 weeks, because the half-life of the enzyme is reasonably short. And then the postnatal care would be just standard as you would in any other setting. And then we would do yearly checkups. And it's a phase 1 trial, so the primary objectives are whether it's safe and whether it's feasible. And then the secondary objectives are more efficacy. So are we decreasing the glycosaminoglycans, which are the toxic byproducts of not having these enzymes? Are we inducing tolerance to the recombinant enzymes so that ultimately we could wean them off the immune suppression? And then what are the long-term outcomes in terms of cardiomyopathy or neurologic function, et cetera? So there are, of course, important safety considerations. The maternal risk of multiple in utero infusions are likely similar to multiple in utero transfusions that we do in other settings. The added consideration that we'll be checking for is there maternal exposure to the recombinant enzyme? We think that it's going to be a low dose because it's dosed for a fetal weight of, say 500 grams. And so it'll be a small exposure, and the mother hopefully will not develop sensitization because she is a carrier and is therefore making the enzyme. But it's something that we are going to check for every single time we do the infusion. And then in terms of the fetal safety considerations, I think it's very important to make sure that when we do this, our in utero injection safety record is excellent. So all of these are done by Dr. Juan Gonzalez at UCSF, and when we looked at his record of 123 in utero transfusions, we had excellent survival. There is, of course, some risk of preterm labor. A lot of these patients are hydropic, et cetera. But I think it's very important to sort of look at the record of the MFM performing these, because these are not fetuses in most cases who would need an in utero infusion for other reason. And then we have been surveying patient groups around the world. Our survey results from the American MPS Society are back. And the questions we have are, so these are parents of children with MPS disorders. So when we ask them, what is your likelihood of ending a pregnancy, a subsequent pregnancy with MPS? The likely is the blue here. So about a third of them were likely, but most of them were not likely. And then their likelihood of choosing fetal enzyme replacement therapy for a future pregnancy, 2/3 of them said that they were likely. And when we framed it as, well, it's a phase 1 clinical trial, so there's no guarantee of efficacy, still the majority of them said that they would be willing to participate in a phase 1 clinical trial. And the feasibility considerations are very important, right? We're not doing carrier screening routinely for these pregnancies. So as I mentioned, we think that most likely it's going to be in families who already have affected children and will obviously require international collaborations to make sure that we can disseminate this protocol around the world. So to that effect, we just wrote a grant that we're hoping to hear from in the next couple of months to really build an international alliance that links together patient advocacy groups, and these are some of the ones that we've been in contact with, lysosomal storage disease experts, so these are the pediatric medical geneticists who are taking care of these children around the world, and of course fetal surgery societies such as this one, to really support patient access to therapy, establish clinical guidelines, and standardize postnatal analysis to see how well we are doing. And so please contact me if you're interested in participating. We would love to just make sure that we include everybody from around the world, given how rare this disease is, and also given how simple it really is. This isn't a fancy stem cell trial. This is just taking the enzyme from the drug company and infusing it into the umbilical vein. And I'd really love to work with as many of you as we can. So in conclusion, we think that enzyme replacement therapy is a promising new treatment. Our enrollment is going to be starting soon. We're just waiting on UCSF regulatory approval, and we will be open for international patients. Obviously, it's challenging in the time of a pandemic, but we have permission for our other stem cell clinical trial to enroll international patients. And our goal is to disseminate the therapy around the world. And again, please contact me if you'd like to participate. And this is, as I mentioned, it's really thanks to our multidisciplinary clinical team that I'm representing here, particularly our LSD expert, Dr. Paul Harmatz, genetics experts, MFM interventionalist, and ethical guidance from Dr. Koenig. So thank you, and I'd love to take any questions.
Thank you very much for an excellent talk. Again, new challenges. I wonder whether is Tessa there? Tessa Humphries. This is a geneticist in England, whether the uptake of termination in a subsequent pregnancy is so low in England as it is in the United States, if I got you correctly. You said that 2/3 of the women that have an affected child will not contemplate a termination in a subsequent pregnancy. Is that true, TP? Yeah.
That is what the survey results said, and we were also surprised by that. But I think it just goes to show how personal these decisions are, and you know that you know, for one thing, we need to make sure that when we develop a therapy, that it's going to be acceptable to the parents and patient community. And that, you know, as practitioners, we simply have to do non-directive counseling and, you know, present the menu of options, including termination, doing nothing, or doing a fetal therapy to the family and have them choose.
So the enzymatic, I cannot find Tessa. She was there earlier. The enzymatic therapy, is it applied postnatally or not? Is anybody being treated postnatally?
It's applied postnatally, yes. So this is basically when a child is born and, you know, they're diagnosed often on a newborn screen or sometimes after the sort of diagnostic odyssey of, you know, not knowing what's wrong for some months. But these are all diseases for which there is a FDA-approved enzyme replacement therapy. So what we're doing with this trial is simply taking that enzyme and giving it to the fetus. And it's only because in this day and age you need regulatory approval for things like this that we had to get regulatory approval. But really, it's kind of an off-label use of an approved therapy.
The rationale, again, just to summarize it for me, is twofold. Firstly, that you will induce tolerance to the enzyme. And secondly, that you hope that in utero, you will be able to cross the brain barrier. Is that the case?
Yes, that's exactly right. Crossing the blood-brain barrier is really important because so many of these children, the enzyme replacement therapy maybe treats there's multi-system manifestations, right? So the enzyme may treat their liver disease, it may treat their heart disease, but the children are still very severely neurologically delayed. And so in some cases, they're having to get the enzyme infused into the brain. But even a short period of getting into the brain before birth and treating those the special cells in the brain called microglia to decrease the inflammation can be very, very effective. The other thing, of course, is that some of these patients have hydrops in utero, especially the MPS 7, and so they don't survive to birth. And we know from other settings that if you treat the root cause of the hydrops, that you can improve survival. So we're hoping that giving the recombinant enzyme can prevent the organ damage that's resulting in the hydrops in utero.
Again, we start off with a family with an affected child, presumably. They will present to you, hopefully in the first trimester, you will have a CVS. At 12 weeks, you will have the results. When do you start giving the transfusions? 16, again, 18 weeks? Or?
Probably 18 weeks. Dr. Gonzalez usually does the transfusions at 18 to 20 weeks. I think and you would know best, of course, Kypros, is the procedural risk of doing an umbilical vein injection before 18 weeks is higher. Yeah. So at UCSF, we've been doing them at 18 to 20 weeks.
And then carry on every 2 weeks? And
every 2 to 4 weeks.
How do you decide the 2 or the 4 now?
Well, we left it vague because we want to have that window, how did the mother handle it? Is there any possibility of preterm labor? Are they traveling to San Francisco to get these infusions, et cetera? So the half-life of the drugs are between 2 to 4 weeks. And so just like you would for in utero transfusions, sometimes we do them at 2 weeks, sometimes 3 weeks, sometimes 4 weeks. We just wanted to leave it open to clinical judgment.
And then aim for delivery at 36 weeks. Could go a bit earlier, no?
Again, clinical judgment. Yes.
I think so.
Yes.
Have you managed to get anybody? Have you seduced anybody?
Well, we had a referral with MPS 7 actually about 1.5 years ago, which resulted in us thinking about this clinical trial. We applied to the FDA and within 1 week, they gave us emergency approval, but the fetus got very sick and developed anhydramnios. And so we decided not to treat that patient. But then from that experience, the FDA encouraged us to just write the full IND to do a clinical trial. So we have not launched the trial officially yet because we're just waiting on the UCSF ethical approval. Hopefully it's going to come in the next couple of weeks, and then we will launch the trial.
Wish you well. Again, perhaps TP, if we produce a notice, we can put it on the website of the Fetal Energy Foundation, because obviously you would need an international collaboration, as you recognize, to identify the patients. But thank you very much for coming again, and good luck.
Thank you very much.
Thank you.
Wonderful to be here. Thank you.
Has Michael reappeared?
Yes.
Fantastic. Did you fix the problem?
I hope so.
We all hope so. Let's try.
Okay. I am sorry about our technical difficulties earlier. I was saying when I started that not all patients with cirrhosis are the same. And in fact, what we have been scared about as liver doctors and obstetric doctors is that the history has taught us that we have potentially 10% rates of death in women with cirrhosis going into pregnancy. We have rates of variceal bleeding potentially of up to 40% and rates of ascites formation of 20 to 25%. In fact, the data that I am talking about are derived from relatively small cohorts of patients from single centres, and indeed these are data from King's College Hospital over several eras. Now what you can see in fact is that the rates of pregnancy in patients both with cirrhosis and without cirrhosis, even in a single centre, have increased dramatically over each 4 or 5 year era. Now, the best population-based study has just been published in the last few months. These are data from the province of Ontario in Canada. And what you can actually see is that over a period from 2000...
Michael, again, you're not projecting the right slide.
I'm afraid I don't see them either. Should we move to the slides that Daniela and Alguero have, and we could project them and you speak to
Please
them?
do. I'll speak to them. I'll get rid of my...
Do you have them, Alguero? Yeah.
Yes, I do.
So if we can go from the second slide. Okay, next slide, please. If you follow data from Canada, what you can actually see that over a period of 20 years, that the rates of pregnancy have gone up by actually a 7 to 8-fold over the last 20 years. And also what is noteworthy is in fact that if you look at data specifically at etiology, what we can say safely now is this is a cohort of 12,000 pregnancies in women with cirrhosis. 70% of all pregnancies are derived from patients with fatty liver disease. And what this actually means is that obstetricians and as hepatologists, we are seeing a huge burden of undiagnosed disease. Now, contrary to what is in the literature, we are finding that overall in all patients with cirrhosis, the rates of pregnancy are actually going up. And in patients with decompensated liver disease, meaning more severe liver disease, actually these are the patients that are of most difficulty in managing. Can we have the next slide, please? Next slide.
There's a conspiracy against you, Michael, but don't
there is a definite conspiracy. So what I was saying is that actually as obstetricians, what you are going to be seeing is a huge burden of undiagnosed disease, mainly because of patients with fatty liver disease. In fact, with these patients, particularly with fatty liver disease, what we also can recognize is that the pattern of complications that these individuals have, these patients have a 10-fold increased risk of cholestasis of pregnancy. So this is something that was not known up until the last few weeks. What we can say, however, is that in general, if you have cirrhosis, actually, by the year 2020, it is important to stratify patients. And if you stratify patients according to whether or not they have previous complications or not, the rates of death or transplantation for all patients with cirrhosis are now actually less than 1%. In contrast, if you have decompensated disease, pre-existing cirrhosis with known ascites or previous variceal bleeding, what we can say is that these group of individuals are the ones that you have to watch out for. And in fact, of 2,000 patients with cirrhosis in whom there is data available in terms of knowing whether or not they had pre-existing cirrhosis, this is the group of patients we need to be careful about, because of these, this is the group that are more likely to have variceal hemorrhage, develop renal failure, or ascites. So the take-home of the largest published series, best quality data derived from 6 different data sets, if you have compensated cirrhosis, meaning no complications going into a pregnancy, your risk of problems, death or liver-related events is relatively low. On the other hand, if you have decompensated disease, the rates of death are higher. Next slide, please. Now, these are also US-based data, and what these actually show from a previous era is that cirrhosis in pregnancy is associated with increased cost. This data does not seem to have the same depth as what I have shown you, but these are some of the statistics that you will be aware of. Slightly increased rates of fatal death, slightly higher rates of preterm delivery, higher rates of growth restriction. But again, what I would say to you is that not all patients with cirrhosis are the same, and what we'll focus on next is how to stratify in your clinical practice who are the patients that are at risk. Next slide, please. Next slide. So there are a number of tools that you can use for stratification, and we have been studying these stratification tools here at King's for the last 2 decades. This was our first study that we showed. Now, nephrologists understood and obstetricians knew that abnormal creatinines were a problem if you had cirrhosis, and in fact, MELD score is a formula that uses bilirubin, albumin, and creatinine in a formula that calculates a score of risk. If you have a MELD score of 15 points, it means that you're sick enough for transplant. Below 15 is considered well-preserved liver disease. But actually, if you have MELD scores as low as 10, it allows you to be stratified into higher risk of decompensation. And as your sodium level becomes affected, this also impacts on the likelihood of having a liver-related event in pregnancy. Traditionally, we have used the Child-Pugh scoring system, and in fact that uses 5 variables, including bilirubin, albumin level, clotting parameters, the presence of ascites, and the presence of encephalopathy. A score of 7 puts you in that mid-grade, and that when you start getting 7 points, that also is a stratifier in terms of likelihood of decompensation or an adverse event in pregnancy. Next slide, please. Now, we have also updated our data set with over 130 patients with cirrhosis with individual patient data. And actually what you find is that with MELD score and MELD sodium, which is a UKELD type of score based on an American formulation of the calculation formula, you find that sodium remains very important with creatinine, but in fact, in truth, when you have enough patients to look at the most important variables, it's something called ALBI score, that relationship between albumin and bilirubin that is most important. And similarly, the relationship between AST and platelets. So platelets are important, albumin important, bilirubin important. Next slide, please. So indeed, what you find is that this ALBI score, this relationship between albumin and bilirubin, allows you to predict the likelihood of live birth in pregnancy. Next slide. If you next slide again, if you stratify according to the relationship between albumin and bilirubin, you can stratify according again into well compensated, moderately compensated, and a poorly compensated patient. Patient with lower levels of albumin, higher levels of bilirubin. Next. And what you find is that the likelihood of getting to term goes down as this relationship increases. So this is a very important point to understand. It's all about albumin, all about bilirubin. Next slide, please. And again, this AST to platelet ratio becomes very, very important, and it is particularly important when it comes to looking for varices. We know that the physiology of cirrhosis often mimics that which you see in pregnancy, vasodilatation, and add to a big volume of blood and it changing. What you can do is when you look at platelet count against AST ratio, you also find that the gestational length gets impacted. Next slide, please. Now, if you are having patients with a known diagnosis of cirrhosis, they need to be screened for varices, if possible, prior to pregnancy. If they have no varices prior to pregnancy, then you are in a position to reassure them. The difficulty comes if you have unidentified varices, because these, in fact, unidentified cirrhosis are the patients who are more likely to run into problems. Next slide. If you perform periconception endoscopy, actually what you can do is you can plan and treat ahead of time the findings. And in fact, if you have pre-pregnancy counseling with a team who are tuned in to the needs of patients with cirrhosis undergoing pregnancy, they're much more likely to be screened. In the study that I showed you from Canada, less than 10% of patients were actually screened for varices. So this is important. And if you have varices going into pregnancy, important that they have an endoscopy in the second trimester so they can be dealt with and a plan made for delivery. Next slide, please. With regard to the catastrophic complication of bleeding, what do we do as gastroenterologists? Well, beta blockers we use to prevent variceal bleeding in both the pregnant and non-pregnant state, and of course you're familiar with the side effects. If you're in an acute bleeding situation, octreotide is what we use. Terlipressin is problematic for the uterine blood flow, and of course antibiotic therapy is an independent risk factor for prognosis if you have a variceal bleed. So antibiotics, vasomodulators in the form of octreotide, and after a bleed the introduction of beta blockers. Next slide, please. So if you have patients with cirrhosis, what do they actually want? In our pre-pregnancy counseling clinic at King's College Hospital with Kath and Leonie Penna and Lisa Long, we have identified a range of parameters that patients are interested in. They want to know, is their health going to deteriorate in the pregnancy? What are the risk of death? Because they will understand that reading the literature, they will have seen 10% death rates. It is nothing like that in 2021. They want to understand the rates of pregnancy loss, which are actually fairly low if managed, and the side effects of medication. So the paradigm for improving outcome really is about pre-pregnancy counseling, managing and assessing their portal hypertension, calculate the risk scores, and my takeaway is albumin, bilirubin, and platelets are the key parameters to be looking at. Review their medication, get a second trimester endoscopy, a delivery plan, and then plan for breastfeeding and contraception. So I will leave it there, and I apologize for the plethora of technical difficulties that I have had this afternoon, and I'll take questions.
Thank you so much for an excellent talk, despite the problems. I'm going to start with a question relating to albumin and bilirubin. Albi grade 3, is it better to wait for transplantation before pregnancy?
Well, I think the key question is if you are going into many patients who have cirrhosis may have, and particularly the patients that we see in our pre-pregnancy counseling clinics, they have had cirrhosis for many years. They have been told they shouldn't get pregnant. So often when they come to us, they're in their 30s, and as everybody in the room knows, that makes it much more difficult. If you then ask them to wait to get transplanted, that adds further time. Ultimately, it depends on the severity of their liver disease. But as you can certainly see, the likelihood of both getting a good outcome is going down. So you're getting patients who unfortunately will be delivering earlier and making life more difficult for the team that are looking after them. Of course, transplantation, it is a good outcome, and you're then looking at dealing with complications of lifetime of immunosuppression, but that is a separate discussion.
Yes. There is a question, would you recommend periconception or very early pregnancy beta blockers for those with a variceal bleed in a previous pregnancy?
So good clinical practice would actually state that if you have had a previous variceal bleed, your varices should be either eradicated or you should be on a beta blocker going into pregnancy. And of course, this is why if you have known cirrhosis, having your screening is absolutely critical. So absolutely beta blockers, they save lives in the pregnant and in the non-pregnant cirrhotic state.
Yes, I agree. Almost everyone who has had a previous bleed does present to us if they come for pre-pregnancy counselling on a beta blocker. And possibly the next question is of relevance to multidisciplinary working as well. It's asking, where can we access MELD score assessment?
So MELD score is now widely accessible through a whole range of websites for people with access to up-to-date. It's there. It is attached to the British liver transplantation website, and there are lots of UKELD and MELD calculators online. It's readily available. But MELD score, very important. ALBI score, just look at the level of albumin. It is simple. Everybody has access to it. Once you begin to have levels below 35 grams, you're likely to run into problems. And platelet cutoff of 100, platelet count of 100, easy to remember, and again, more likely to have varices in both pregnancy and without pregnancy.
There's a question, does Budd-Chiari in particular give you a higher risk compared to other cirrhotic liver disease or chronic liver disease?
So again, the very useful information that has come from this Canadian study is that in the group categorized as other, it includes some of the vascular liver diseases. It doesn't seem to be associated with increased pregnancy risk. Of course, patients with Budd-Chiari syndrome will also have that additional risk of being prothrombotic. So their coagulation needs to be managed appropriately. And again, I think that is something where the hematologist, the obstetrician, the hepatologist needs to come together.
Yes. There's a question, do you think there should be any difference in approach between spontaneous pregnancies or pregnancies after IVF with egg donation?
So the answer to that is we're unsure. There is very little published in relation to cirrhosis and IVF. We're about to publish the rates of implantation are certainly much lower, but again, the same rules apply. If you are going into IVF with severely deranged liver function, your rate of complications from IVF is higher. So so when you get ovarian hyperstimulation, that seems to be more severe in women with IVF. But again, it's all about planning.
Yeah, I absolutely agree. Pre-pregnancy counselling and hopefully no more than one fetus. There's a question about contraception.
So
your advice on contraception for cirrhosis women.
In patients with cirrhosis. So women with cirrhosis, I'm a big fan of recommending implantation devices. The complication rates are actually very low, both in terms of infection and in terms of tolerability. We recommend pregnancy only or progesterone only contraception for predominantly, but actually for early liver disease or compensated liver disease, I have had no significant complications from low dose estrogen containing pills. And in fact, in post-transplant patients, the FDA have pretty much made that type of statement as well. So I think I'm fairly broad-minded.
I think, although again, there are so many wonderful questions, maybe we should finish on an interesting question that asks you, is there any way you would recommend trying to screen for cirrhosis in women not known to have previous cirrhosis in pregnancy?
So I think the challenge for obstetricians is in your patients who are overweight, the risk of fatty liver disease is undiagnosed in the same way as these are the patient cohort that are going to get more likely to get gestational diabetes, hypertension, preeclampsia. And in fact, this is the tsunami that is coming everybody's way. And of course, in the Canadian study, the majority of these patients that were found to have cirrhosis in pregnancy, it was undiagnosed prior to pregnancy.
Very important message. Thank you so much for an absolutely excellent talk. And thank you to all the speakers today. It's been a fantastic session, and I'll hand back to Kipros. Thank you for asking me to organise it.
Well, I'm very grateful to you, Kathy, for putting together such a fantastic program. I thank the many, many thousands of you that have participated again, and I wish you all a happy new year. We will move on to the next slide for the next webinar. Ayero, if you have it there. So Kathy, start preparing for sometime in the beginning of March.
With pleasure.
Maternal medicine session. We are having the next webinar will be on the 31st of January. And we have a great group of speakers on pre-implantation prenatal diagnosis, whether it's worthwhile or not. There you are, okay. Professor